Good evening. Thank you for coming, joining us tonight in this CPD event. My name is Eirini. I'm one of the surgeons at the RALF. I did my surgical training at the University of Liverpool. I finished my residency in October 2021, and I've been working for the RALF for more than a year now. So when the team they asked me if I would like to do a CPD, I thought it would be a good idea to talk about head and neck surgery. We get referred frequently cases that need investigation of a neck swelling or cases with ear conditions that require surgical treatment, so I hope this is going to be interesting for you. So in the first part, we're going to talk about surgical conditions of the salivary gland. Then we can have a little break, or if you have any questions, and then we can carry on later with discussing common ear surgical procedures. So to start with, an anatomy reminder. So the salivary glands in cats and dogs, we divide them into major and minor. On the left side of the screen, you can see the major glands in the dog and the cat, and on the right side, the minor salivary glands. So the dogs, they have 4 pairs of major salivary glands. These are the mandibular, sublingual, parotid, and zygomatic. In the cats, we have 5 pairs. There is a well-developed molar salivary gland, which is located deep to the buccal mucosa at the angle of the jaw. This is not developed in dogs. So the major salivary glands, they are sat at a relative distance from the mouth, and they drain saliva via ducts. The minor salivary glands, the buccal, labial, lingual, tonsillar, palatine, and molar, they drain directly into the mouth. So saliva doesn't go through a duct and then into the mouth, but directly into the mouth. So this is a nice photo showing the location of the major salivary glands. In the cats, here we see a dog, but it's the same in cats and dogs. So this is the parotid salivary gland. I hope you can see it, otherwise I can point to the screen. It's located superficial to the vertical ear canal, as you can see. Cranial, we have the temporomandibular joint and the masseter muscle, which is missing from here. It attaches ventral at the zygomatic bone, and then it goes further ventral to the ramus of the mandible. Caudal to the parotid salivary gland, we have muscle bellies, the sternocephalicus, sternomastoidus. There are several small ducts that leave the gland at the rostroventral aspect of it, and they course cranially at the ventral part of the masseter muscle. And then they form the major parotid duct, which opens at this level, at the level of the carnassial tooth, the 4th upper premolar. So this is the orifice of the parotid duct. Then the zygomatic salivary gland is located ventral to the eye globe and medial to the zygomatic bone, which is missing here. It has several ducts opening into the mouth. The major one opens approximately 1 centimeter caudal to the parotid duct, so at the level of the last upper molar tooth. Then the ones that are more of interest, to be honest, is the mandibular, the complex mandibular sublingual salivary glands. And these, they go together because they share the same capsule, so we don't separate them. We will see later when we do surgery, we remove them as a whole. So they are located at the angle of the jaw. The mandibular and sublingual salivary glands, they are located ventral to the parotid salivary gland. The mandibular is the most caudal and the largest, as you can see. Then cranial to it, we have the sublingual part. The sublingual salivary gland is divided into monostomatic and polystomatic portions. So the monostomatic portion is all these that you can see here. This part, the caudal part of the monostomatic gland, shares the same capsule with the mandibular salivary gland. Then their ducts, the sublingual and the mandibular, they travel cranial to empty at the sublingual caruncle, cranial to the frenulum. I thought these pictures, they give us a very nice idea of where exactly these glands are located, the complex mandibular sublingual salivary glands. There are good anatomical landmarks that we need to consider when we do surgery. So they are located, as we said, at the angle of the jaw. This muscle that I'm pointing here, I hope you can see, is the digastricus muscle. This is a good landmark when we do surgery, as we will see later. We need to identify this. And then you can see here the salivary glands coursing rostrally, opening here The sublingual duct is located lateral to the mandibular and it opens slightly caudal to it. Then on this, I think this is a nice photo showing where exactly the glands sit relative to the jugular vein, the mandibular lymph nodes, and the medial retropharyngeal lymph nodes. So the mandibular salivary gland sits at the bifurcation of the jugular. So we have the linguofacial vein here, and then the maxillary vein going dorsolaterally. The mandibular lymph nodes, they sit ventrally and cranially to the mandibular, to the complex actually, of the salivary glands. So they produce saliva, all of them, minor, major. The saliva has several functions. First, it lubricates the ingesta. It helps forming food bolus, which is then packaging it to swallow it and send it to the esophagus. It helps with thermoregulation by cooling as it evaporates. And of course, it contributes to oral hygiene by removing debris from the teeth, by having antimicrobial activity, and by buffering weak acids and bases. If we look at the salivary glands from a histological point of view, we will see that they contain serous secreting cells and mucus secreting cells. The ones that secrete highest serous, they have the highest serous secretions is the parotid and submandibular salivary glands. The highest mucus secretions, they come from the sublingual and zygomatic salivary glands. So in theory, you could say if you have a sialocele and you aspirate, based on the viscosity of the fluid, you could guess which gland is affected. But that in theory, because the location of the sialocele would give us a better idea of which gland is affected, to be honest. So saliva is produced by smelling food, by touching the food, touching our tongue, tasting it. The main conditions which actually are of interest to us are the last three mentioned in this slide. Basically sialoceles, this is the most common condition that we deal with from a surgical point of view, which we will talk, of course, in length in a bit. The first two conditions, sialadenosis and sialadenitis, they are non-surgical conditions. These cases, they affect usually, these conditions, they affect usually the mandibular salivary gland. These cases will present with enlargement of the gland. The cases may have hypersalivation, lip smacking, and weight loss. This is what the history will include. The sialadenosis is a non-inflammatory process, contrary to the sialadenitis, which is an inflammatory process and leads to necrotizing sialometaplasia. Both of these conditions, they have been associated with a limbic epilepsy, so they don't tend to respond to antibiotics, steroids, or even surgical removal of the salivary glands, but they respond to phenobarbital. And if that's the case, you keep the patient long-term on this medication. Salivary neoplasia is a condition that we don't see, to be honest, very frequently, rarely. And we will see how we will manage it later. We will talk briefly about it. Sialoliths, again, very rare in dogs and cats. When we see it, we may see a sialolith in a case with a sialocele, for example. Treatment, if there is no sialocele and it's just a sialolith on its own, you can remove it surgically. You can tie off the duct of the affected gland. You could even remove the affected gland. In case where you tie off the duct of a gland, what's going to happen? Basically, the gland is going to become atrophic. So this is a way of managing them. So the sialoceles, it's a condition where we have collection of saliva in the subcutaneous tissue. They are lined by inflammatory connective tissue. Unlike a cyst, a true cyst, where the fluid is coming from the epithelium, the lining of the cyst, here the saliva comes directly off the gland, so we don't have a proper lining. The cause of the sialoceles is unknown. They can be caused by sialoliths, by neoplasia, by trauma, or even recent oral surgery. So if you've done a mandibulectomy, you may have a ranula after type of a sialocele we will see later. So the most commonly affected gland is the sublingual salivary gland, specifically the monostomatic part. These cases present as a non-painful swelling that may fluctuate in size. And the clinical signs depend on the location, depend actually on the location of the affected gland, as we will see. The most common, actually, of the most common presentations is the cervical sialocele. So typically we will see a swelling at the ventral aspect of the neck. The gland that is affected is the sublingual, of course, the monostomatic part. Sometimes in these cases, depending on where the swelling is, how big it is, where it's located, if it's very caudal and you have the patient standing, you may not be able to determine which side is affected. So in these cases, the patient should be assessed in dorsal recumbency under anesthesia, and then gravity will lead you, will give you the answer. The swelling or the sialocele itself will shift towards the affected side. Another common presentation is ranula or sublingual sialocele, as shown in the photo here. So you will have a swelling under the tongue. Depending on how big the swelling is, you may have deviation of the tongue medially to the other side. The most common, actually the typical signs of a ranula or sublingual sialocele is dysphagia. So the client will report to you that the dog cannot grab the food, they cannot chew it, they cannot swallow it, and the gland that is affected is the sublingual salivary gland, the monostomatic or polystomatic portion. A relatively uncommon type of sialocele is a pharyngeal sialocele. So you will have swelling at the pharynx, rostral cranial to the epiglottis. The typical presentation will be respiratory signs. So the patient will have dyspnea, stridor or stertor, depending on how big it is. If it's very big, the patient is at risk of airway obstruction. So these cases, they may present to you as emergency cases. In this case, we would have first, we should focus on stabilizing the patient and then dealing with the sialocele. So what you can do, you can drain directly. However, it may not give you the decompression that you would like on the swelling. So maybe a better idea would be to get a blade and just incise it. And once the patient is more stable, then you could proceed with marsupialization or sialadenectomy, as we will see a little bit later. Another relatively uncommon presentation is a zygomatic sialocele. So these cases will present with exophthalmos. They are not very common, and to be honest with you, I have not been lucky enough to have dealt with one so far. You may have protrusion of an eyelid and the painless orbital swelling. If the sialocele is very big, you may be able to see it on examination of the mouth. And of course, the gland that is affected or leaking saliva is the zygomatic salivary gland. You can see here in this image is a CT transverse image, soft tissue window of a dog with a zygomatic sialocele. In this case, they have performed CT sialography. So basically, they have catheterized the orifice of the zygomatic duct, and they have injected contrast. So you can see the arrowhead here is pointing to the sialocele. So this is the sialocele itself, and the structure pointed by the arrow is the zygomatic salivary gland. And you can see its position ventral to the eye and medial to the zygomatic bone. So how we will diagnose sialoceles? History and clinical presentation, typical, you will have a soft tissue, a swelling, which is going to be soft on palpation because it's going to be fluid filled. These cases, they won't respond to antibiotics. If you give them a course, they will come back, the swelling will still be there, maybe smaller in size or a little bit bigger. And then to confirm the diagnosis, if you aspirate it, you may get a honey-colored fluid. It will be viscous, or it can be blood-tinged if someone else has aspirated it before. On cytology, what you will see is several inflammatory cells. So you may see lymphocytes, neutrophils, macrophages in a proteinaceous background. You can confirm the diagnosis on cytology by performing a PAS stain. To be honest, this is not something that I do routinely because we send our samples. You can send it to a clinical pathologist and they will do it for you and they will send their report and there you go. Diagnosis of sialocele. So the PAS, the periodic acid sieve stain, is a mucin-specific stain. So it will stain mucin, which is in the saliva, pink to violet. Imaging, again, is part of our investigations, and at the referral setting, we do it routinely. you could argue, if you have a case with a sialocele and you have aspirated it and you know that's a sialocele, based on the fluid that you aspirate, the presentation, everything fits with a sialocele, someone could say, why do I have to spend money and do imaging? I think by doing imaging, you can rule out other pathologies, and also you can check for pathologies affecting the salivary glands themselves, because you may have a case with neoplasia, for example, that led eventually to sialocele. So it would be nice to know before you proceed with surgery. CT sialography that I'm mentioning here, I don't do it routinely, but I think it's an excellent idea. And as we will see later, it may help you identify which gland is affected specifically. The reasons that I don't do it routinely is because sometimes it can be a faff, especially in very small dogs, in cats as well. You can imagine the size of the patient is not very easy to catheterize the duct. So it can be tricky sometimes, depending on the location. But the image that we saw before from the zygomatic sialocele, I think it's a very nice image, and we will see some later as well. Other diagnostic modalities, you can do an ultrasound, so you do ultrasound-guided aspiration, radiography, or MRI. MRI, again, I don't think it's needed. Cost, duration of the study to perform it, and so on. So CT probably is more than enough. So here I have this is a case that I had in the hospital. This is Bailey. Bailey was a French bulldog, young adult. He was around 4 years old. He presented to me with swelling on the right side of the neck. So it's a transverse CT image, soft tissue window again. We have given contrast, so the vessels, you can see them all highlighted. This is the digastricus muscle, and then this is the sialocele here, you can see it. It's just fluid attenuating material medial to the salivary gland, which is here, and then you can see the big vessels, the maxillary and the linguofacial merging into the jugular. I want to show you other structures nearby, which are our landmarks, as we said before, other than the vessels. This is the digastricus muscle here, this is the masseter muscle. Here, so this is the mandibular gland, and this is the linguofacial and the maxillary merging, okay? So this is digastricus here, this muscle here, and then this is masseter. And then these are the mandibular lymph nodes. You can see them here. This is a mandibular lymph node, and this is our sialocele. And these are the glands here, mandibular there, and then maxillary and linguofacial. This is how a cervical sialocele is going to look on CT. So here, these are nice images, again, after people have performed CT sialography. So they have catheterized the duct of the affected gland, they have injected contrast, and they got these nice images. Both are transverse CT images, soft tissue windows. I just wonder if anyone, or if you would like to have a guess or think which salivary glands are affected in these images by looking at them. So in both cases, after catheterization here, so this is the sialocele on the left image, and this is the salivary gland highlighted here, pointed by the arrow. And here, this is the sialocele, all of this, and this is the affected gland pointed by the arrow. Do you want to guess? You can say what type of sialocele it is based on what we discussed before, so it could be either cervical or a ranula, or a zygomatic. Any guesses, Miren? Parotid, this one? Yeah. Parotid, this one, because you can see the gland is highlighted here with the contrast, and the gland itself is located ventral to the ear canal. You can see the ear canal here. And also, if you compare this side, the right side, this is the left side on here. So the right side is a little bit more swollen than the left, and it's on the side of the face, so it can't be anything else. Of course, it would be better if you would scroll through the CT. I'm sorry, I'm giving you still images, so it's not fair. And then this one, do you want to have a go or guess? So this is here, we are at the level of the larynx, so we are at this point. So it would be the most common presentation of a sialocele, a cervical sialocele. So this is how a cervical sialocele would look like on CT. All this is saliva here, like fluid attenuating material. This is a very nice image, and it shows, it confirms what we discussed before. So if you do CT sialography, imagine that you have this case presenting to you. You can see that the swelling is like evenly spread on both sides, right and left. So it's not easy to say which side is affected. By doing xylography, we know that it's the right sublingual salivary gland affected. I can tell it's the sublingual because of the distance of these two vessels, the linguofacial and the maxillary, but again, you should scroll through and then you will have your answer as to whether it's sublingual or mandibular salivary gland. With regards to the treatment, sialadenectomy is the bestest option with the bestest outcome. Draining the sialocele is not going to resolve the problem. The sialocele will recur eventually at some point. So for the cervical sialoceles, the ranulas and the pharyngeal sialoceles, we do mandibular and sublingual sialadenectomy. For the zygomatic sialoceles, we remove, obviously, the zygomatic salivary gland, and for the parotid sialoceles, the parotid salivary gland. There is no point when you are in theater and you are doing a sialadenectomy to excise the sialocele itself. No point. It's not a cyst. It doesn't produce anything. There is no true lining there. It's pseudo lining. So you can just drain it. You will eventually get into it and you will have saliva leaking during your surgery anyway. But there is no point attempting excision. So there are two different approaches for mandibular sublingual sialadenectomy. The ventral approach is what I usually do, but this is my preference. For this procedure, you position your patient in dorsal recumbency with a sandbag under the neck, and then you start your incision a few centimeters caudal to the angle of the mandible, caudal to the vertical ramus, and then you extend cranially, medially, or at the level of the mandible. So you incise your skin, your fat, the platysma muscle, and then you will see the capsule of the salivary glands. Remember, linguofacial maxillary vein, this is where at this angle you're going to find the salivary glands. After incising the capsule, you will have something like this. So this is the mandibular salivary gland, this is the sublingual, and we carry on dissection further forward under the digastricus muscle. So there is a mosquito artery forceps passed dorsal to the digastricus muscle. At this point, when you are at this point, what we need to do is place a ligature here and transect this tissue. So this comes off, and then with the mosquito, we grab our stump and we pull it rostral and medial, dorsal to the digastricus muscle to continue our dissection here. So we have the digastricus muscle laterally and the muscles of the tongue medially. You may have to incise and elevate the mylohyoidus muscle. You carry on dissecting around the sublingual salivary gland and the ducts of the mandibular and sublingual ducts up to the level of the lingual nerve, which is not shown in this image, but it should be at this level. So you want to go as far cranial as you can without damaging the lingual nerve, without damaging the hypoglossal nerve, which should be at this level as well. You will see them as nice, fine, white structures. So this is the ventral approach, how you would perform it. You can perform the lateral approach. I would say do whatever you're most comfortable with. When I did my surgical training, I started doing the lateral approach because this is what my supervisors did. But then after I tried the ventral approach, I thought it's much easier and it gives me better access. So for the lateral approach is again something similar, it's just you have the patient positioned in lateral recumbency. Again, you can see the jugular, the bifurcation, and this is where you need to cut. So you can make your incision as it's shown here, like vertical, or it can be that way, like parallel to the jugular vein. Again, it's better if you do digastricus tunneling rather than doing myotomy of the digastricus to continue your dissection, which is a little bit more invasive. You have to tunnel in order to maximize your chances of removing gland as far cranial as you can. So you have to dissect between the masseter muscle here and the digastricus to continue your dissection cranially up to the level of the lingual nerve if possible. You will have, if this is the location here of the salivary glands, you will have your mandibular lymph nodes here. I forgot to mention that this is, I hope you see, this is rostral is to the left on this image. This is just a reference. I'm happy to give you any references if you want after of the technique described. Basically, it's a cadaveric study and they showed that if you tunnel under the digastricus, you increase your chances of removing salivary tissue at the most rostral part, so you minimize the chances of having a recurrence of a sialocele, basically. So we said ventral approach, lateral approach. What shall we do? What you are happier with? There is a study from 2021 from the Veterinary Surgery Journal. They compared these two. So what they concluded is that if you have recurrence, it's more likely you will have it with a lateral approach. The ventral approach, though, was associated with more wound-related complications. So they had seroma, swelling, dehiscence, all associated with the ventral approach. The overall complication rate in the study, although it sounds quite high, it was like around 25%. These were all minor complications. The recurrence rate, which was on the lateral approach, it was 4%, so quite low. And then these cases obviously were revised by doing the ventral approach. Again, another positive thing probably of the ventral approach is that you can remove the glands bilaterally. You can just make your incision on the midline and then you have access to both, rather than doing incision, changing recumbency and so on, if you are to remove them bilaterally. But someone could argue, what are the chances that you will have to do bilateral? Anyway. So complications of the surgery, you may have a seroma, depending on how big the sialocele is. You can place a drain if you like to decrease the chances, if you have loads of dead space, of forming a seroma. You may have swelling, infection, or dehiscence. The last two are, the incidence is like similar to any other surgical procedure, like standard soft tissue procedure. I wouldn't say it's anything big. Of course, we need to advise the clients to wear buster collars, not leak the wound, wound care, and so on. Other complications, you may have hemorrhage from the lingual artery when you dissect, nerve damage. We want to preserve the lingual and the hypoglossal nerves. And then recurrence. Recurrence would not be very nice. The actual incidence of recurrence is probably reported 4 to 14%, but I would say overall probably less than 5–10%. So recurrence would happen because of two reasons, either because we have done incomplete excision of the salivary gland, or we have removed the wrong side. So in order to address the problem, it would be very nice to do imaging, so we see if there is any residual salivary gland. And then if you have recurrence, then probably I would consider performing a ventral approach rather than the lateral, and try to excise tissue as far cranial as you can. Marsupialization is another procedure which you can perform. We mentioned it for rannulas, for pharyngeal sialoceles in the beginning, but rannulas probably are good cases to do that. So the procedure is very, very simple, but very simple. You will just make an oval or elliptical incision on the swelling. You will drain the saliva, and then using absorbable monofilament suture, you will suture the oral mucosa with simple interrupted sutures as shown in this image. You suture the oral mucosa to the lining of the sialocele. There is a study under review where we tried to look into the outcome of marsupialization of rannulas and having the marsupialization as sole treatment. It's still under review, so it's not out. But I can tell you that probably 1/3 of the cases of rannulas that were treated with marsupialization, they had recurrence. So there was some recurrence, but the majority of the cases with rannulas, they responded well to marsupialization only. So you could consider it as a first-line treatment for a rannula. Of course, warn the client that you may have to perform a sialodenectomy in case of recurrence down the line. And again, a good option for pharyngeal sialoceles, but for the pharyngeal sialoceles, because we said that it's the complex affected or leaking, the mandibular sublingual, we should better do sialodenectomy as well. For zygomatic sialodenectomy, again, these are cases that we don't see frequently, and if I was to perform this case for the first time and I was in general practice, probably I would consider, these are the cases that I would consider referral. The reason is we don't operate frequently in this area. We just need to be familiar with the anatomy and have good knowledge of the regional anatomy. This image here, you can see that we are working very close to the maxillary artery and vein, and also the facial and deep facial vein, which are in very close proximity to the gland itself, which is located here. There are several approaches reported if you look into the literature on how to perform a zygomatic saladenectomy. What probably most people prefer is a modified lateral orbitotomy approach, where you will approach your zygomatic arch on the side, and then you will do parallel osteotomies, cranial and caudal, and basically you will reflect the zygomatic bone ventrally by preserving the masseteric attachment at the ventral aspect of the bone. There are other techniques described. So here, this paper, these are images from this paper where they compared the non-ostectomy techniques. So basically, they preserved the zygomatic bone, and they approached ventral or dorsal to the zygomatic bone. This is the ventral approach. So they made their incision. The zygomatic bone is highlighted by the asterisk. This muscle belly here is the masseter muscle, masticatory muscle. It's reflected ventrally, and then you can see here, this is the, I hope you can see it, the facial vein, and exactly here, so very close, is the zygomatic salivary gland. They found that it's easier if you approach ventrally. They do report a dorsal approach as well, but with the ventral approach, you increase your chances of complete excision of the gland. The dorsal approach was much harder to take the whole gland out. So in general, to summarize, because there is too much information, also lastly, I wanted to say before we summarize, there is another recent paper where they did zygomatic saladenectomy through an intraoral approach. I'm only mentioning it so that you know that some people do it somewhere in this world, but, and I can give you the reference as well if you would like to have a look, of course. So for the zygomatic saladenectomy, you can do ostectomy approach or non-ostectomy approach. You can remove the zygomatic bone. You don't have necessarily to replace it after you do this, but you can, if you want, by pre-drilling holes and placing a suture to hold it in place after. Or you can do the non-ostectomy here. This study in particular is a cadaveric study, so I'm just mentioning it so that you are aware that it's in the literature, but it was a cadaveric study, not actual clinical cases. Parotid saladenectomy, again, the anatomy is, it would be good to be very familiar with it before you perform it. Medial, we discussed earlier in the anatomy, the first couple of slides, where it's at relative to which structures. Very important, what we need to remember is that medial to the gland, we have the facial nerve. Responsible for facial expressions, blinking, and so on. So we definitely want to preserve that. And also, medial to the parotid salivary gland, we have the external carotid and its branches. So what we could do to make our life a little bit easier and protect these structures, we could inject methylene blue, which is, you can inject a few mils diluted in saline. You can inject them either directly into the duct, which is shown here. So you can dissect the duct, you can inject methylene blue, and then you can highlight the whole salivary gland, as you can see in the middle photo. And then we have the facial nerve here, pointed by the arrow. After removal of the parotid gland, here you can see the muscle belly, then the arrowheads are pointing to facial nerve branches, and then here, this big vessel is the external carotid and the branches. Again, probably these are cases that maybe it would be worth referring. Historically, parotid saladenectomy is associated with high morbidity, so up to 35%, and also there is risk of damaging, of course, the facial nerve. Probably that was around, reported like 15% or so. What about cats? It's very rare having Sialoceles in cats. This is the study that they included 19 cases, and this is the largest case series of cats with saladenectomy. So you can imagine it's not something that we see frequently. Personally, I have not seen one. I would love to see one at some point. So what they, in these cases, they had the exact similar presentation with dogs. So the presentation of the Sialoceles was cervical, parotid, and so on. Again, glands that were affected were the ones that we've seen in dogs. So mandibular, parotid, sublingual, but not molar, because you remember we said cats have a fifth pair of major salivary glands. The molar was not affected in any of the cases. In 11 of the 19 cases, they did surgery, saladenectomy. The rest were managed conservatively. And conservatively, we say they describe either just draining it and the sialocele resolved, or marsupialization, or tying off the duct of the affected gland. These were more than enough, and they had no recurrence. So probably this gives us an idea, and it suggests that maybe cat sialoceles respond better to conservative management, and we don't have to do cell adenectomy. But again, this is a small number of cases, only because the condition is quite rare. Salivary gland neoplasia, lastly, again, not a very common condition. However, you may have the odd case. You can see this is my odd case. This is Dave on the right side of the screen. Dave is a 10-year-old Labrador that I saw 8 months ago. This is his CT on presentation. So it's a CT transverse image, soft tissue window. You can see this abnormal structure here. It's heterogeneous and contrast enhancing. This was salivary carcinoma, which is the most common type of salivary gland tumors, rare of epithelial origin. The most commonly affected glands are the parotid and the mandibular. In this case, for Dave, the mandibular was affected. Of course, we sampled it. We found out it's a carcinoma. We did staging. This statement here, high metastatic rate, recurrence rate, comes from a very recent paper in the Journal of Veterinary Surgery, where the recurrence rate is quite high. So they report a recurrence rate of 40% and metastatic rate around 30%. So you can understand that this condition is not easily treatable, or you cannot cure it, basically. So what is recommended is that we do surgery to remove all this. We do cell adenectomy, we do metastasectomy if there is any spread to the lymph nodes, and then adjunctive treatment, chemotherapy or radiotherapy should be advised to the clients. For Dave in particular, the clients didn't want to do anything, so Dave went home when we did the initial surgery. Everything was perfect until a couple of weeks ago when Dave came back with the clients. They felt at the surgical side, on the right side, this is the right side, towards the left. So they palpated this. You can see it at the bottom image. This is a CT again that we did here. They felt a firm nodule, probably olive size. We did restaging. We had not, although we had recommended it, we didn't follow up the case. So we decided, the clients consented to restage. We did another CT. We saw this. You can see here that this is the contralateral salivary gland. Obviously, there is no here, none. Hopefully, I had removed it at the initial presentation. And also, the other thing you can see is that here, you can see the structure. I hope it's highlighted by the laser point. This is the medial retropharyngeal lymph node, so there was metastasis to it, which you can see here. Again, it's missing. I'm happy it was missing at the second CT. This, we went ahead with surgery. We removed it in K-Bacchus carcinoma. It was just at the surgical site. So this is in agreement with the study that reports high recurrence rate. I think this is what I had to say about the sialoceles and the salivary glands. If you have any questions, you are more than welcome. And then we can carry on, probably, if there aren't any, or if there are any, welcome, more than welcome. I don't know if you see, do you do surgery on sialoceles in practice a lot? Do you see a lot? No? Usually most of your neck swellings are abscesses? Yeah? Yeah. We do get referred lots of neck swellings for investigation, particularly this time of the year. They are abscesses, most of them. But we do get the odd sialocele, which is nice. Yeah. Have you seen any of the more experienced people in the room? I don't know, have they seen a sialocele in a cat? No? Yeah?
No, I've only ever seen sialoceles in domestic animals.
Okay.
Do you know if there are any records of this condition
in other animals?
In wild members of the cat and dog family?
I haven't looked into this, unfortunately, but because obviously I'm doing only small animals. But in theory, I would say probably yes. If I had to guess, I would say yes, but I don't know, is my answer. We can look into it. Interesting. Any questions? No? Okay, we can carry on with the second part then. So the second part, do you do any of these, total ear canal ablations or VBOs in practice? No? Some of you may do, but you may be shy to say. So the total ear canal ablation, lateral bulla osteotomy, and ventral bulla osteotomy, these are the most common ear procedures, surgical procedures that we perform on ears most commonly. So again, we're going to start with an anatomy refresher. So when talking about the external ear canal, we all know that it consists from the vertical part and the horizontal part. There are three different types of cartilage in the ear. We have the auricular cartilage all the way down the external ear canal, and then the annular cartilage at the level of the horizontal ear canal just before we enter the bulla. There is a third cartilage, if you read the textbooks, the scutiform cartilage, which I find very interesting. It sits rostromedial to the ear. I just included this photo only because for me it's interesting, this cartilage. Basically, it's nothing significant. It was part of the cranial helix and then it detaches at birth. It just stays there, so nothing important. So when you do external ear canal surgery, the most important structure that you need to be aware of is the facial nerve when you dissect around the ear canal. And of course, we saw before that we have the parotid salivary gland in the vicinity. So the facial nerve, I hope you can see it here in the image, sits exactly here. So close to the junction of the, you can see it, can you see it? Yeah, close to the junction of the vertical and the horizontal ear canal. It exits the cranial vault caudal to the bulla. So if the dog's nose is that way, and the bulla is here, basically the facial nerve is going to exit at this level and it's going to course rostroventrally. This is why we have it, we may meet it at the junction of the vertical and the horizontal ear canal. So this is the structure that we need to have in mind when we do a TECA, for example. With regards to middle ear anatomy, the middle ear, we tend to say tympanic bulla and we refer to the whole thing here, which should be all air-filled, including the external ear canal that we saw earlier, and here is the level of the tympanic membrane. There are three chambers, if we would want to be more specific. So we have the epitympanum, mesotympanum here, and then the tympanic bulla, the hypotympanum, this big area here. This dot, this black area here is the auditory tube or Eustachian tube. This is the communication between the ear and the nasopharynx. And it opens at the level of the mesotympanum. In the epitympanum, we have the ossicles, the auditory ossicles here, the malleus, incus, and stapes. Here is the inner ear. We all know that middle and inner ear functions are hearing and balance. So the middle ear is separated from the inner ear through these windows here, so oval window and round window. This is the area that we should be the most careful when we do a TECA and lateral bulla osteotomy. So dorsal and medial to the middle ear. Here is the promontory area, the bony promontory. It houses the cochlea. So the inner ear, we have the cochlea, the vestibule, and the semicircular canals. We just need to be careful again when we do curettage during the TECA, as we will see later, because this is where the sympathetic trunk will be. So this is, if you damage this area, then this is why you may have Horner signs, as we will see later. Indications for a TECA, total ear canal ablation, lateral bulla osteotomy, chronic otitis externa or media that is refractory to medical management. I would consider it if you have a non-compliant patient, so it's very difficult to medicate them, apply eardrops, give steroids orally and so on, or if the client is really struggling to do that for you frequently as you would want to. Neoplasia, this is a condition that we see, I would say we see it quite frequently in the cases that are referred to us. Ear canal neoplasia, we're talking about ceruminous gland carcinoma, so tumors of epithelial origin, or squamous cell carcinomas, you may see the odd one in a cat. Another indication is cholesteatoma. Cholesteatoma is a non-neoplastic condition. It's basically an epidermoid cyst within the middle ear. It's non-neoplastic, but it behaves like a cancer. This is an image on the right side of the screen of a cholesteatoma. You can see it's very destructive here. So all this is the tympanic bulla. It should be air-filled, like on the other side. This looks more normal. But you can see that we have bone lysis, sclerosis of the temporal bone here, and maybe some erosion of the bone at this level. So it's a keratin debris, basically, surrounded by keratinized stratified squamous epithelium. It's very destructive. The patient may present to you with neurological signs, so head tilt, ataxia, and it needs very aggressive surgical management. So you need to remove all the keratin debris, even the bulla wall. Because it's very difficult, though, in most of the cases, this will come back. So there is a 50% recurrence rate if you deal with a cholesteatoma. When you perform the surgery, what you will see macroscopically is probably white, yellow, soft tissue material. You could perform a TECA, total ear canal ablation, lateral bulla osteotomy, if you have done a lateral wall resection or a vertical canal ablation that has failed. For these conditions, they do have these procedures, they have a high complication rate, wound associated. If you have trauma or avulsion of the ear canal, if you have a paraoral abscess because of trauma, then you would consider doing a TECA-LBO to treat it. There is a question whether you would do unilateral or single-stage bilateral. There is evidence that shows that it's okay to do single-stage bilateral and that the complication rate is similar for both, rather than staging the procedure. It's just my personal preference. I would like to do them staged. Only because it's a painful procedure, and if you have complications, it's nice to deal with one side first and then later on with the other. But this paper, where they reported similar complications between the two approaches, whether you do staged TECAs or you do both in one go, the complications were slightly higher on the single-stage bilateral, to be honest, if we look at their absolute numbers, but this was not a statistically significant finding. Very important, when we work up a case with an ear condition, you can do hematology, serum biochemistry, what you do routinely for any case that you investigate. Imaging, I would say it's quite important. Here are two cases with otitis media, externa as well. So the case on the left is Gracie. Gracie is a very old Cocker Spaniel. She presented with bilateral ear disease, as you can see here. On the CT, this is a transverse CT section. This is a bone window. For a change, you can see mineralizations in the ear canal, the external ear canal, along the external ear canal. On the left side, you can see that there is narrowing of the external ear canal as well. And then there is middle ear disease, of course. All this should be air-filled, and it's not. The bulla is filled with soft tissue or fluid attenuating material. So it's quite important in these cases to have imaging and know what you're dealing with, because when you dissect around the ear canal, you may meet these mineralizations at this level, and you may think, oh, I have reached the bone, when you haven't, and all you are having in front of you is just mineralization. So it can be misleading, especially if you have not performed the procedure several times. This is an MRI image. It's a T1 sequence with contrast. So I've only included it just to show you here that there is bilateral. We are at the level of the tympanic bully here, the middle ear. But it's quite subtle, probably. You just need to pay attention where I'm pointing now. If you compare this side with this side, you can see that there is contrast enhancement here. So you can see a white line. This is meningeal enhancement, and it means that the condition is extending into the brain. So this is why sometimes it is important to know the extent of the disease, so you can advise treatment and obviously meet clients' expectations as well, or explain to them what the outcome will be. It's very difficult in some cases to say whether you have a disease affecting the meninges on CT. So MRI probably is a better modality to consider. With regards to the procedure itself, you need, other than your standard soft tissue kit, you need these instruments. So Alice tissue forceps at the top left to hold the ear canal when you are dissecting. Self-retaining retractors, Gelpi retractors. You need a freer periosteal elevator to elevate the soft tissue from the bulla when you approach the bulla, and then rongers or Kerrison rongers to perform the bulla osteotomy. You could do that with a mallet and an osteotome, and then a curette, Volkmann curette, when you clean the bulla and you remove the epithelium. It's very nice to have an assistant. I would say have an assistant when you do a TECA. Don't attempt it on your own. It's not going to be very pleasant. Positioning, you position the patient in lateral recumbency with a sandbag under the neck again. These procedures are not clean anyway, because most of the cases they're very infected. So give perioperative antibiotics. They don't affect your culture results later when you collect the sample intraoperatively. You could do the steps of the procedure. You could do an oval incision, so around the opening, the entrance to the vertical ear canal, or you can do a T-shaped incision. Although I did not attend this year the ECVS Congress, the Congress of the European College of Veterinary Surgeons, there was a study there which is not out yet. What they found is that, they presented the results there. What they found is that when you do an oval incision, with this approach, you increase the risk of damaging the facial nerve. Whilst with a T-shaped incision, you may have wound-associated complications more likely. Let's wait for the study to come out and then we can talk about it more. So the top tip, you have an assistant, and also you dissect as close to the ear canal as possible. When you make your incision, you include all the abnormal tissue that you can see macroscopically when you assess the ear, and you just stay ventral to the tragus, which is at this level here. This is where the tragus would be. So you do your oval incision, you stay as close to the ear canal when dissecting. You have in mind that you may meet the facial nerve codoventrally, close to the junction towards the horizontal ear canal. Top tip, do not twist the ear canal when you do it. So your assistant have them to keep the ear upright without twisting while you dissect around, because you may lose your orientation and you may not be able to dissect as close to the ear canal as you would like. Once you have reached the bulla, you dissect, you amputate the external ear canal close to the bulla, and then you have to clean if you have remaining cartilage around with rongers, and then you can do your bulla osteotomy by using the rongers or a mallet and osteotome. The safest area to do it is here, ventrally, codoventrally. Avoid to use your rongers, especially, you can do it later to clean this area, remove any cartilage or epithelium that you may find there, but I would leave it last, do it in the end, dorsocranially, because this is where the retroglenoid vein is. It runs through the bulla into the bone, so by cutting it, you may get it and you may have bleeding, which is not pleasant at all if you have that, because then you cannot see anything. So I would leave this area to clean it probably at the end, at the very end, once you have done all the rest. If you have bleeding from the retroglenoid, no panic, you can stop it, you can pack, you can put your swabs there and wait for 10 minutes. You can use ice-cold saline to stop the bleeding, or even you could use bone wax if you have available at the practice. You would just place some bone wax and hopefully that would be it. But the bleeding normally resolves after you pack it or you use ice-cold saline, no problem. Then once you have done your bulla osteotomy, of course, you have better view, so you can use your curette to clean and remove the epithelium. I would say be very careful when you clean dorsomedially. So if you have the dog in front of you, at the dorsomedial aspect, be gentle, don't do overzealous curettaging, because this is where the auditory ossicles are, this is where the windows are, the oval and the round window, and then you may damage the inner ear by accident. Once you have removed all the epithelium, you can take a swab. So I would take the swab post-lavage. Of course, we lavage a lot. Post-lavage, it has been shown that lavaging actually decreases the number of bacterial isolates by 33%. So take your swab after you have cleaned everything, just by not touching skin or subcutaneous tissue. Collect the swab and then wait for the results after the patient has recovered. We do this procedure in cats and dogs. Probably I find it a little bit easier in cats. In cats, though, you will lose the support of the vertical ear canal when you do it. So you can do this very simple advancement flap. and then the ear is going to stay upright, so you won't have a bad cosmetic outcome. Very simple, very easy. You can just use the skin and do the flap. Post-operative management, analgesia, very important. It's a painful procedure. We're talking about multimodal analgesia, so methadone post-operatively for sure, non-steroidal anti-inflammatory drugs, paracetamol if you can give, if there are no other conditions and you can administer this medication. If you are confident and happy, I am not, you can perform blocks for additional analgesia. Our anesthetists, our lovely anesthetists at the Ralph, they do it for me. So you can block the great auricular nerve or the auriculotemporal nerve. You block both, so you block the cranial and the caudal part. You can use bupivacaine, this is what they use normally. And this will last for 6 to 8 hours after, so it's additional pain relief. And remember, local analgesia is the bestest form of analgesia, if you can have it, rather than giving opioids. This is general, not about TECAs. The TECAs will need opioid analgesia for sure. Then if you have vestibular signs after, like a head tilt or ataxia, because inadvertently we have damaged the area where we shouldn't dorsomedially, you can give maropitant. Eye lubrication if you have again damaged the facial nerve. And when I say damage the facial nerve, I'm not talking about transecting it. While you place your self-retaining retractors that we saw earlier, you may just stretch it, and this will become, you will have neuropraxia eventually, which hopefully is going to be temporary. So for the time that the palpebral reflex is not working, keep the eye lubricated. So hyalonite, prefer an ointment other than drops, because the drops, they will not last long. Having an ointment is going to be better for eye lubrication. And then antimicrobials. Again, there is another very recent study from JAVMA, the 22, a relatively recent paper, where they looked into post-operative infection rates. And surprisingly, they followed the cases more than 6 months. The more you move from surgery, the more, the higher the complication becomes with regards to infection. So what they advise in this paper is give antibiotics post-operatively within a month from surgery, no later, and give the antibiotics based on the susceptibility results that you have from the swab that you collected intraoperatively after lavage. Complications, you may have hemorrhage. We did mention already, you may have hemorrhage from the retroglenoid vein. This is why we will leave working on the craniodorsal aspect in the end. There was a very nice picture which we saw earlier. Sorry, I'm going to go back a little bit just to show you this, because you may have hemorrhage from other structures as well. Here, this is the bottom image, is an image from the Evans anatomy book of the dog. You can see this is the bulla. Here, the vessel, this big vessel is the common carotid artery, and you can see we have the external carotid here and the internal carotid dorsally. So, ventral to the bulla. If the bulla is, if the dog, again, the dog's nose is that way, and you have the bulla, you will have the external carotid and maxillary artery and vein ventral, and you will have the internal carotid medial. So if you have advanced disease that is affecting the bulla, it's causing lysis by curetaging, you may damage the carotids. I would say this is very, very rare, and you have to be very, very unlucky. But in theory, you may have bleeding from the retroglenoid vein and also from, in theory, from the carotid arteries. So facial nerve paralysis, so absent blink, very, very common, like very common. 40–50% of the cases, they will have it after surgery. Transient in most of the cases, it should resolve within 6 to 8 weeks if we have not severed, like transected, cut completely the facial nerve. For as long as the patient is not blinking, we recommend eye drops, artificial tear drops. Horner syndrome, more common in cats, because the sympathetic trunk in cats is more superficial. In the dogs, it's more deep, more protected in the promontory area. Horner syndrome, the signs that you will see typically is miosis, ptosis, so drooping of the upper eyelid. You may have an ophthalmos, you may have protrusion of the third eyelid. These are the typical signs of Horner's. You may not necessarily have all of them, you may just have one. If you see these. Surgical site infection, to prevent having a surgical site infection, again, give perioperative antibiotics. Then take your swab after you have lavaged, wait for susceptibility results, give the appropriate antibiotic within a month, we said. Vestibular syndrome, quite rare. We just need to be very careful when we curettage and we remove the epithelium during the procedure. It should resolve. Again, if you have any form of neurological signs after a TECA, it should resolve. They should go away within 6 to 8 weeks. I would say past this point, maybe we should warn the client that this may be permanent. Paraoral abscess, probably the most devastating complication of a TECA. It can happen quite late. So don't expect that the paraoral abscess is going to happen 2-3 weeks after your surgery or 6 months. It has been reported up to 6 years, so it can be a very late complication, and it's not very nice to deal with at all. Hearing loss, we should warn the client, especially if by accident we have damaged the ossicles that we saw in the middle ear, then the patient is not going to be able to hear. There may be some hearing loss by conduction through the bone, but if we have performed the procedure bilaterally, and it's a cut, for example, and it's an outdoor cut, what we should say to the client is to keep them indoors. Otherwise, it's not, the cut is life-threatened, basically. It can be killed and attacked, as they won't be able to hear anything. With regards to the ventral bulla osteotomy, here the procedure, we do it mostly in cats. You can do it in dogs as well. Again, this is something, if you would consider doing it in dogs, maybe this should be performed by an experienced surgeon. The anatomy is a bit more different. It's much easier to palpate the bulla in the cat, not that easy in dogs. We consider indications for ventral bulla osteotomy, inflammatory polyps in cats, or when you have middle ear disease only. By doing a ventral bulla osteotomy, you won't have access to the external ear canal. So here is the middle ear of a cat. It's a bit different from the dog, which we saw earlier, because the cats, they have a complete septum. You can see it here. So it's the middle ear is properly divided into 2 chambers, the ventromedial compartment, which is this big area, and the dorsolateral. When we do the ventral bulla osteotomy, we have to perforate the septum to reach the dorsolateral compartment, because this is where the polyp will arise from most commonly. So there's no point just cleaning the ventromedial compartment. You need to perforate the septum and reach the other area. With regards to the nerve structures, they are at the same location as in the dog. We just said that the sympathetic trunk is just more superficial in the promontory area here. This is a CT image of a cat. This cat had external ear disease. This was a ceruminous gland adenocarcinoma, and we did a TECA in this cat probably a month ago, if I remember well. I am just showing this. This is a transverse image. The cat is not very straight. That's why you cannot see the septum on this side. But this is how the septum will look like. So this image is helpful. Imagine that we are doing now a ventral bulla osteotomy. Basically, your approach is here. So from the ventral aspect. When you do a ventral bulla osteotomy, we said we need to approach the dorsolateral compartment as well. So you need to perforate the septum. The safest area to do that is here. You need to stay as lateral as possible. So if I am, I stay on the right side of the case and the head, the rostral aspect is there, I need to access the dorsolateral compartment by entering the septum, I'm very sorry, this way. So your patient is in dorsal recumbency. You can see on the left side of the screen, there are sandbags under the neck to help with basically elevating the bully a little bit, so you can palpate them much easier. You need to tape the upper jaw to the table, so again, everything is stable and more exposed. This is where the bully are in this cat. Landmarks, you have the body of the mandible, the trachea here, the larynx at this level. So if you read the textbooks, to locate where the bulla is, you can draw a line from ramus to ramus, as shown in this picture here, and then a perpendicular line on the midline, and then 2 centimeters from where they cross on either side, you can locate the bully. However, you can palpate them easily. So the approach to the bulla, once you know where it is, it's very simple. You just make a skin subcutaneous tissue incision, you incise the platysma muscle, and then you have the digastricus muscle laterally and then medially the muscles of the tongue. Structures that we would like to protect in the area, the linguofacial vein, the lingual artery, the hypoglossal nerve. I would say relatively easy approach. Easy approach. Here, these are images from surgery. I hope you can see. So this is the cut that we did the drawing earlier. This is lateral. So the right side of the left image is lateral, medial to the left. So we palpated the bulla, we did our incision, our approach. You can see the linguofacial vein here. You can retract it either medially or laterally, wherever is easier for you. And I'm not sure if you can see here very well this structure. This is the lingual artery. So we preserve it. The bulla basically sits here. Just here where I'm pointing now. We have placed our self-retaining retractors, we have located it, and we keep dissecting. You can use your freer periosteal elevator to get all the soft tissues away, so you have the bone exposed. So this is we've done already the bulla osteotomy by using a Jacob's chuck and Steinmann pins. You can instead use a spinal bear or a bear if you prefer and if you have the equipment in the practice, but you can do it very simply with the Steinmann pin and the Jacob's chuck. So we have accessed the bone, so we have removed this part of the bone in this picture, and you can see that there is material, not nice material, coming out of the ventromedial compartment. Then to carry on with the procedure, you use your Kerrison Röntgens and you remove the bone around, so you expose the whole ventromedial compartment in front of you. And then again, this is just a reminder, you need to perforate the septum at this level here, as lateral as possible to stay away from all the nerve structures. Post-operative care, Elizabethan collar, of course, in the cuts, soft, analgesia, opioids to start with, then non-steroidal anti-inflammatories. Eye lubrication. With the VBO, we don't have facial nerve paralysis as high as you would expect for the TECA. So I haven't seen personally a facial nerve paralysis, although it's reported in the textbooks as a complication. And then antimicrobials, after you have collected your bacteriology swab at the end of the procedure, after lavaging everything and removing the epithelium, you can prescribe the appropriate antibiotics if needed. Complications, very common. Horner syndrome in cats, very, very common, but very common, like 70%. And then in some of them, in only very few, it will remain permanent. We did say Horner signs, enophthalmos, meiosis, ptosis, and protrusion of the third eyelid. Vestibular syndrome, so the cat may wake up if you have done excessive overzealous curotaging with head tilt, ataxia, not being able to stand. Hopefully these signs will resolve with time. When we do VBOs in cats, if we have bilateral disease, probably it's wiser to stage the procedure and not do single stage VBO like we could do in theory for a TECA. There is evidence for this from a paper from 2019. Again, I'm mentioning references every now and then while I speak. I'm happy if anyone is interested to have the references. They recommend don't do it because you may have airway obstruction from pharyngeal swelling. So even when you do unilateral, still there is risk of the cat developing pharyngeal swelling. So keep an eye on respiration post-operatively. And then recurrence of middle ear disease, this is another complication you may have. If we have not cleaned everything very well, then this obviously would require a revision surgery. Not very nice, if that's the case. So that's all about VBOs as well. This is a photo from Greece. It's one of my favorite areas. It's very nice because there are not many people, as you can see. Very nice, probably it says here it's nice and warm and summery. Thank you all for coming.